Okay, chest tubes. Let's talk about chest tubes for a few minutes. So let's start off by thinking about, why does our patient have a chest tube? Okay, and on the Nclex, you're going to see stuff written or described differently than you may commonly see it in your facility or at your nursing school. Your instructors may call it something differently. So on the Nclex, you very well may see a chest tube referred to as a closed chest drainage device, or maybe just as a chest drainage device. And the purpose for a chest tube or a chest drainage device is to reestablish a negative pressure in the pleural space. We want to reestablish a negative pressure in the pleural space. And that's because we typically, on a normal person, have negative pressure in the pleural space. Now, what is the pleural space? Well, that is the space, and it's a tiny, thin space between our chest wall and the lining around our lungs. And normally those two surfaces are pressed up against each other, and there's a vacuum in between, so that as our chest expands, it sucks the lungs with it, because the lungs are essentially adhered to that chest wall, which causes the air on the inside of our lungs to have a negative pressure, which sucks air in through our mouth. Now, if there, for whatever reason, that chest wall does not draw on that pleural lining, then the lung is not going to have negative pressure inside of it, and it's not going to expand. So as a result, our patients are going to have difficulty breathing or a collapsed lung. Now, how does air get into that pleural space? How does air get into that little tiny gap between the chest wall and the lining of our lungs? Well, there's two ways. You can either have a hole in the chest wall, or you can have a lung in the lining around the lungs. So a hole that comes from the chest wall could be from a gunshot, it could be from a stab wound, it could be from some other sort of accident. And what happens then is that you'll have a sucking chest wound where there will be air going in through the chest wall into that cavity. So now when you go to take a breath in, instead of our chest drawing the lung with it, instead of the chest wall drawing the lung with it, it's just going to draw air in through that hole in the chest wall. A second reason that you may have air in that pleural space is if your patient has a hole in their lung, a hole through that lining around the lung, and then that's where the air is getting in. So that as the chest wall expands, air goes through the lung, which keeps the lung from expanding and filling with air. So these patients are going to get short of breath. They're going to have difficulty breathing. You're going to hear diminished breath sounds on that side. So that's why we use a chest tube. We use a chest tube to reestablish that negative pressure in that pleural space. And so what we've talked about thus far is removing air from the pleural space to keep that negative pressure. But there's a second reason that you may need a chest tube, and that's if there's a fluid collection in that pleural space. And again, that could come from the same situations. Instead of having air going in, it's could be blood or another fluid going in. So, if a patient has a chest injury from a gunshot, from a stab wound, from some other sort of trauma, it may not be that air has gone in there, but perhaps there's hemorrhaging internally, which is then collecting in that pleural space. So the lung is then not going to be able to expand because there's fluid in the way. So we can use a chest tube to remove that fluid and allow the lung to fully expand. So the locations of those tubes are going to change. Okay, so you'll either see a tube placed apically, and that is for air, and you'll see that placed high on the chest. So apical locations are to remove air from the pleural space, and they're going to be placed high. Or you may see a basilar location, B-A-S-I-L-A-R, a basilar location, and that's going to be placed lower. And that's going to be placed lower to pull out some blood, okay? Because blood obviously is going to collect on the bottom of the pleural space, and air would then collect on the superior part or the apical part of the chest. So think of it this way. Apical is for air, basilar is for blood, right? And so the A's go with the A's and the B's go with the B's. Apical air, basilar blood. On the Nclex, though, you're going to see the medical situation referred to as a pneumothorax or a hemothorax. So the pneumothorax is with air, and the hemothorax has blood typically. So a patient may have either one of those, or they may have both of those, which would be a pneumohemothorax. Okay, so how many chest tubes is a person with a pneumothorax going to have? Well, if it's a unilateral pneumothorax, so there's only one side of the lung is collapsed, then they're going to have one tube, and it's going to be located apically. So a unilateral pneumothorax will have one tube located apically. And we know that because a pneumothorax is going to be taking out air, and air comes out apically. Okay, apical air, basilar blood. So what if a patient has a bilateral hemothorax? Hemothorax. Well, hemo is for blood, so we know that the blood is going to be found basilar. And if it's bilateral, then they're going to need to have two chest tubes, and they're going to be located basally, one on each side. So a bilateral hemothorax will have two tubes located basally. Now, what if a patient has a unilateral pneumohemothorax? How many tubes are they going to have? For a unilateral pneumohemothorax, our patient is going to have two tubes, right? One's going to be located apically to take out the air. That's the pneumo part of their pneumohemothorax. And then they're going to have one located basally for the blood that's part of their pneumohemothorax. Right? And on the Nclex, unless it says otherwise, you're going to want to assume that it's unilateral, right? Unless it specifies otherwise. And if a patient is coming to you from any sort of trauma or a surgery, you're going to assume that it's a pneumohemothorax. One of the units where I work frequently is a CT surgery unit, a cardiothoracic surgery unit. And there we see patients who have had cabbages, other heart surgeries. We see esophageal surgeries, and we see a lot of lung surgeries. And the one time that we don't see a chest tube for a lung-related surgery is if a patient's had a pneumonectomy. Okay, a pneumonectomy is where an entire lung or a part of the lung has been removed. And for that, they don't need a chest tube because there is already a negative space created by the removal of that lung tissue. Okay, so there's already a negative space there, so they don't need a chest tube, unless it says otherwise, unless it says that it's draining blood from internally related to that surgery. So one of the things that you need to be careful with the chest tube, and chest tubes have changed a lot over the past 50 years. It used to be these 3 canister devices where you'd have a tube that came from the patient's chest and went into a collection bottle that collected any fluid that was drained. And then there was a second bottle that was the water seal, where the tube from the first bottle would go to the bottom of the second bottle, and then there was water that it went down into water. And then there was a tube that went from the top of that to another tube that was establishing the vacuum pressure. And then that tube then continued on to the vacuum source, essentially to the wall. Now, these 3 canisters have been combined today into a single canister system. And the Nclex isn't going to ask you a ton of different stuff about this because now there's a million different manufacturers for these. They all work a little bit differently. Different facilities have different ones. So they're going to ask you questions that pertain to all different types of chest tube systems and not individual or specific chest tubes. So what do you do when one of these gets knocked over? This happens. I've done it myself. Most of them have little feet now that fold out, and I'll usually tape those to the floor. That way I'm not so clumsy with them. And they also don't end up underneath a patient's bed. So someone comes in the patient's room, they raise the bed, they're working on the patient, the chest tube gets slid underneath the bed, and then someone goes to lower the bed back down to its lowest position, and you hear this big crunch because the bed is a whole lot heavier than the chest tube. The plastic chest tube collection device is strong, so now you have this broken system that's on the floor. It's a huge pain in the butt. So what do you do when that happens? We're going to go through these situations. So if the canister gets knocked over, you set it back up, and then just have the patient take a couple of deep breaths, and that's just going to get everything moving again. It's not a big deal. Just set it back up. The second thing is, what happens if the water seal in the device breaks? Okay, so now the whole point of this is that you had a one-way system. So now when the water seal breaks, you have a two-way system because the water is not keeping stuff from being able to air or other debris or fluids from going back up into the patient. We don't want things to go into the patient through this chest tube, right? That would be like a really bad idea if you had something go through that tube into the patient. We want it to go out of the patient. And this is a great idea for an Nclex question because it's an ordering question. You can make it an ordering question, or they can make it what's the best thing to do kind of question. Now, if they want to make it an ordering question where you drag things into the box and then put them in order, the first thing you're going to want to do when this water seal breaks and the one-way street is now a two-way street, the first thing you want to do is put up a roadblock. And that roadblock is the clamp on the tube. You want to clamp the tube. Now, you'll always hear in nursing school, never clamp a chest tube. Well, there are certain situations when you need to clamp a chest tube. So what happens when the collection device gets full and you need to put another one on there? Well, you can't just disconnect it. You have, because that's going to allow it to be a two-way street again. So you want to clamp that chest tube and pop off the old collection device, stick on the new one, and now you can unclamp the chest tube. So you're going to clamp the chest tube is the first thing. The second thing you want to do is cut off the old device right down at where the device connects. So you don't need to cut it off necessarily because sometimes you can just pull it off. Right? Then what you're going to want to do is stick the end of that chest tube down into some water. Okay. Now, what that does is reestablishes that water seal, and then you can unclamp the tube. So now any air or fluid that is in the lung in that pleural space, if it wants to go out of the pleural space through that chest tube, it can. Right? It's just going to push out into the water. But there's not going to be enough vacuum pressure to suck that water up through the chest tube into that pleural space. So you've reestablished that one-way street, and there's no way for anything to go back up into that pleural space because the first thing we did was we clamped the chest tube. The second thing is we cut off the tube, or we pulled the tube off at the device. The third thing we did was we submerged it in water to reestablish that barrier. And then the fourth thing we did was we unclamped the tube so that the one-way street was reestablished. Now, what if they make this a what is the best thing to do kind of question? How are you going to look at this now? Okay, so we've changed it from what's the first thing was we were going to clamp the chest tube, to now what is the best thing to do? So the best thing to do is the one thing that you could do that would keep you from having to do anything else. If you were only going to do one thing and that one thing only for the entire rest of the day, what were you going to do? Okay, so let's compare. Clamp the tube versus remove the tube from the device or cut the tube from the device. Well, am I okay only clamping the tube but never disconnecting it from the device? Yeah, I think I'm okay with that. If those are my only two options, I'd rather have it clamped than just disconnected and left loose. Or am I okay with just cutting off from the device and not clamping it? Well, I'm not okay with that at all because now we just established a two-way street and we only want this a one-way street. Okay, a no-way street, just clamping the tube makes it a no-way street. That's better than having a two-way street. Okay, now let's compare clamp the tube to submerge the end in water. Well, okay, am I okay clamping the tube and leaving it that way all day, and not submerging it in water? Or am I okay just as soon as it breaks, I'll stick the end in water and I never clamp it? I'm okay with that, right? I'm okay putting it in water right away and not ever clamping the tube. That's just fine, because we took the two-way street that was established when the water seal broke, and we just made it a one-way street again. Now, what if we said, okay, just submerge the end in water, but not unclamp the tube? Or unclamp the tube, but don't submerge it in water? Well, it doesn't make any sense, because you can't just unclamp the tube, because it was never clamped to begin with. So now you can see how we looked at this by saying, which of these am I not okay to not do? Which of these can I not let myself not do? And so in this, submerging the end in water comes out as the best thing to do. It's not the first thing you would do, but it's the best thing to do. So that's how you need to think about first style questions versus best style questions on the Nclex. Okay, there's a whole other lecture on first versus best style questions and some question examples. So be sure to listen to that. It goes over this in greater detail, but you can see how you can use that strategy on different topics throughout the Nclex. So that's one situation that may happen. That's one thing that may go wrong in your day, is when you smash the collection device. Either the patient steps on it, the stretcher gets rolled over on it, the bed gets lowered onto it. Don't break these, because it's not fun. Just make more work for yourself. So another situation that you might find is that the chest tube comes out of the patient's body altogether, right? So typically these are sutured in place. So hopefully it's not yanking out the sutures while it's yanking out the tube. But if that does occur, you're going to need to know what to do, right? And again, 4 steps here for what to do if the chest tube comes out of the patient's body. First thing you want to do is cover that hole where the tube just came out. Cover it with a gloved hand, right? Typically there's going to be some tape, maybe, and some gauze and stuff if it's a newer chest tube around that hole where the tube went through the chest wall. So you're going to yank that stuff off and then put your gloved hand over the hole. That's the first thing. So cover the hole with your gloved hand is number 1. The second thing you're going to do is apply some Vaseline gauze. The third thing you're going to do is cover that with a dry sterile dressing. And the third thing you're going to do is tape 3 sides of that dry sterile dressing. Now, do you need the dry sterile dressing? Not really, but the tape won't stick to the Vaseline gauze, so you got to have something that helps the tape adhere to the body and to the dressing. And why do we use Vaseline gauze? What's wrong with just the dry gauze? Well, remember, we want to take what has just become a two-way street again and make it a one-way street or a no-way street. And the best thing to do is to make it in this situation, is to make it a no-way street with that Vaseline gauze, because the air is not going to go through that Vaseline gauze. The dry sterile dressing will hold that Vaseline gauze down. And the reason you only tape 3 sides of this is the thought being that if there's air that wants to come out or fluid that wants to come out of that pleural space, and you've taped down 4 sides of the gauze, that the air or fluid's not going to be able to come out. So if there's only 3 sides taped, then it basically makes like a little one-way flap, so that stuff's able to come out in a one-way street fashion and then not go back in, because as the suction would pull the Vaseline gauze back up against the skin and cut off that hole. So in recap there, the 4 things you're going to do in order when the chest tube comes out of the patient's body. First thing, cover the hole with your gloved hand. That takes the 2-way street, makes it a 0-way street. Then you're going to apply Vaseline gauze. Then you're going to, third, cover all of that with a dry sterile dressing. And the 4th thing you're going to do is tape 3 sides. So that's what you need to do if a chest tube comes out of a patient's body. Another thing they may ask you about on the Nclex is about bubbling. Okay, there are 2 times that bubbling can occur in a chest tube or in the collection device. You're not going to see it in the tube, hopefully. So I provided a decision tree here to show you the thought process that you can go through to figure out if the bubbling that you're seeing is good or if it's bad. Okay, so the first thing is you want to ask yourself, where is the bubbling? Okay, is the bubbling in the water seal, or is it in the suction control chamber? And the second thing you want to ask is, when is it bubbling? So the first, I want you to ask where. The second, I want you to ask when. Okay, so where is it bubbling? If it's bubbling in the water seal, the second question we're going to ask is when. When is it bubbling? And if it's bubbling intermittently, as with the patient's breathing, that's a good thing. Okay, so if it's bubbling intermittently in the water seal, that's a good thing. If it's bubbling continuously, that's a bad thing. Right? And what you want to start doing then is figuring out why it's bubbling continuously, because it shouldn't be. Right? That indicates that there's a leak. So you want to check and see if there's a leak in any of the tubing. So you want to check all the connections. You want to start taping up all the joints to make sure that they're all sealed up. And a good way to think about why this is bad is think about that water seal being like a 2-liter bottle of soda, right? 2-liter bottle of Coke. And when you open up that 2-liter bottle of Coke, you start to see it bubbling, okay? And if it bubbles a little bit, that's okay, right? You expect that to happen when you open a 2-liter bottle of Coke. It's going to bubble for a little bit. But if it continues to bubble and continues and continues and continues, that's bad, right? So if you just crack the lid open a little bit, it's just going to keep bubbling until all that air's gone, and we don't want that, okay? So if the water seal, right, that 2-liter bottle lid is the water seal. If the water seal is bubbling continuously, that's bad. Now you get to another question about a closed chest drainage device, and they say that it's bubbling. What do? We say, where is it bubbling? And they tell us that it's bubbling in the suction control chamber. In the suction control chamber. So what do we ask second? We found out where. Now we need to find out when is it bubbling. And if it's bubbling intermittently, that's bad. Right? Like when a patient coughs, this is a good way to check and see if that seal is okay, is you have to ask the patient to cough gently a couple of times. And if you see it bubbling intermittently when they cough, that is bad. That indicates an air leak. We'll talk about that in a moment. If it's bubbling continuously in the suction control chamber, that's good. Right? That's good because the continuous bubbling in the suction control chamber indicates that we have a continuous negative pressure. Okay, so if it's bubbling in the suction control chamber, it's bad if it's intermittent and it's good if it's continuous. Right? So, do you need to memorize all 4 of these? Do you need to memorize this entire decision tree? No, you don't need to. What I want you to do is write it down on a separate sheet of paper, draw this little decision tree out with your 4 possible outcomes. All right, 2 of them are good and 2 of them are bad. Just memorize one of them, because you can deduce all the others if you know that one of them is bad. And we know that it's bad if your 2-liter bottle is always leaking, right? So the 2-liter bottle is the water seal that's always leaking, and that's bad. Now you can deduce that if it's leaking intermittently, that's okay. And you know that if it's not the water seal and it's the suction control chamber, that the opposite holds true. That continuous in the suction control chamber, continuous bubbling is good because that means there's continuously a negative pressure, and it's bad if it's intermittent. So memorize that a 2-liter bottle of soda that's the water chamber, if it's leaking continuously, it's bad, and then just deduce the other 4. That's what good test takers do. That's what people who are good at studying do. They figure out ways to deduce other answers and other information based on what they know. And I'm going to teach you some more of these strategies when we do labor and delivery, okay, for how to deduce other information. So memorize that one, deduce the other 3. Now, I said a moment ago about that a patient has an air leak if when they cough, the suction control chamber bubbles intermittently. And what is happening when the patient has an air leak is that there is either air that is sucking in around the tube going through the patient's chest wall, or more commonly, there's air going through the patient's lung into that pleural space. And what happens then is when they cough, that air moves in and out through the suction control chamber intermittently, and that's what's bad. So how do they fix that hole in the lung? Well, a lot of times it'll resolve on its own. You'll see a stepwise approach to discontinuing a chest tube. So you'll see it first. It might be, orders might say, chest tube hooked to low continuous wall suction at 20 millimeters of pressure. So you'll twist the little knob on the device to 20, and then they may be like that for a couple days. Then after a couple days, they may say, turn off suction and just water seal the patient. Well, with that, there's no more suction anymore. It's just a water seal, so that if anything wants to go out on its own, it can. We've got the one-way street, but it's not being sucked out. And then the last thing they'll do is they'll clamp the chest tube to see how the patient handles it, if the lung is able to continuously expand and contract with the chest wall. And then they'll discontinue the chest tube altogether. So that's what's going on with this air leak. Now, if the patient's hole in the lung doesn't resolve on its own, one thing that you'll see done is they'll try and do a blood patch. And a blood patch is basically where the physician will take the patient's blood or donor blood, and they'll pour it down the tube into that pleural space, into that gap. Well, typically we want to draw everything out of that gap, but what they do with this blood patch is they pour it down in there with the hopes that that blood is then going to coagulate against the hole and basically make a big scab in there. And it's not a super successful treatment, only works maybe 20% of the time, but it's cheap, it's safe, and as a last option, you don't want a patient who has a hole in their lung and has to be on a chest tube for a month. This is something that typically a patient's only going to be on for a few days, maybe a week. That's kind of the goal, is that situation is going to resolve and we can discontinue the chest tube. But if it continues to leak for weeks and weeks, a blood patch may be an option that you'll see the physician team use. So I just want you to understand what it is. Not going to see that mentioned on the Nclex, but just something kind of cool that you may see out on one of your units. So that is it for chest tubes, also known as closed chest drainage devices, also known as chest drainage devices. So if you've mastered this information about chest tubes, you know what every other new graduate nurse knows, and that is what you need to know for the Nclex about chest tubes.